So this is the second module on endocrine disorders, and we are going to talk about the disorder of the adrenal cortex. So the adrenal glands, which sit on the kidney, are constituted by the adrenal medulla, which release the catecholamine, and if you remember, epinephrine is released from the adrenal medulla, and this was discussed in the autonomic nervous system last quarter. And then you have the adrenal cortex that produce the steroid hormones. And this is going to be the focus on this. So there are three classes of adrenocortical hormones or steroid hormones. The glucocorticoids, and the major one is the cortisol. Mineralocorticoids, and the main one is aldosterone, and then the androgen with androstenedione. And as you can see, they have a similar structure and few changes that give their function as either a glucocorticoid, a mineralocorticoid, or an androgen. Androgen will be discussed in the men's health in a different module, and here we're going to focus on glucocorticoid essentially and mineralocorticoid. So what are the physiologic effects of glucocorticoid? They have an effect on the metabolism. So they have an effect on carbohydrate metabolism. They promote glucose availability. So they are actually hyperglycemic. They increase the blood glucose by increasing the gluconeogenesis and reducing the peripheral glucose utilization. They also reduce the glucose uptake by the muscle and the adipose tissue. They have an effect on the protein metabolism, so they reduce the protein metabolism by increasing the protein breakdown and reducing the protein synthesis, so they're going to decrease the muscle mass. In terms of the fat metabolism, they increase the lipolysis, so that means they break down the fat, and that can lead to hypertriglyceridemia. The long-term and high-dose therapy cause a fat redistribution that is characterized by the moon phase. If you see patients on corticosteroids that are on long-term and high-dose corticosteroid, this is one of the characteristics. This is the moon phase. Glucocorticosteroids also have effect on the cardiovascular system, and they maintain the integrity of the cardiovascular system, and they have an effect on water and electrolyte, and they promote the renal sodium and water retention, and promote the potassium excretion, and so that leads to edema. And then same thing, patients who are on chronic and high dose of corticosteroids developed edema over time. In terms of their regulation, they are also under control of a negative feedback regulation. So here, if you see, you have the glucocorticoid steroids synthesis. So the hypothalamus will release the corticotropin releasing factor that will stimulate the anterior pituitary, that will stimulate the production of the adrenocorticotropic hormone, and therefore this one will stimulate the adrenal cortex and induce the release of cortisol. Now, when the level of cortisol is sufficient, then you have the negative feedback regulation on the anterior pituitary and then on the hypothalamus to suppress the release of CRH and suppress the release of ACTH. In terms of pathophysiology of the adrenocortical hormone, there are two forms of adrenocortical dysfunction. You have either, again, hormone deficiency. So adrenal hormone deficiency is known as Addison disease, and then adrenal hormone excess is known as Cushing's syndrome. Let's first talk about adrenal hormone insufficiency, so Addison disease. And JFK, the president JFK, was actually diagnosed with Addison disease. The cause is just a gluco and mineralocorticoid deficiency that results from an atrophy of the adrenal gland. Clinical presentation characterized by weakness, emaciation due to anorexia, hypotension, hypoglycemia, and increase pigmentation of the skin and the mucous membrane. So here you can see that. The treatment, again, if it's a deficiency, you want to replace with the deficient hormone. So here it's a deficiency in gluco and mineralocorticoid. So you can replace with adrenocorticoid and then with glucocorticoid. So hydrocortisone is the drug of choice. Now, what are the uses of glucocorticoid beside the treatment of Addison disease? You have a lot of non-adrenal disorders, and you probably know most of them. So first one, you have allergic reaction, and this is actually my arm when I got stung by a bee here in the US. That's the only time I got stung, but I developed this severe allergic reaction. It was not life-threatening, so I didn't need an EpiPen. But over time, the rash was growing, and I received a shot of cortisone. It's used for the treatment of asthma. So if you remember from your respiratory lecture, so they are used inhaled, like glucocorticoid are used inhaled in patients with asthma. They can be used for the treatment of dermatologic disorders such as eczema, psoriasis, multiple inflammatory disorder, tendinitis, bursitis, osteoarthritis, etc. Also, they are used for the treatment of cancer arising from lymphoid tissues such as leukemia, Hodgkin disease, and of course they are used in conjunction with anti-cancer drug, with chemotherapy agent. They are used to suppress allograft rejection in conjunction with other immunosuppressant agents. They are used for the treatment of certain autoimmune disease such as rheumatoid arthritis or lupus erythematosus, so SLE, and they can also be used for the treatment of inflammatory bowel disease. Now, what are their mechanism of action? They are actually drugs that target an intranuclear receptor. So the receptors, they are going to induce the activation of the transcription of different genes. About 10 to 20% of the expressed genes that respond to the glucocorticoid steroid or glucocorticoid. Mainly, they are cytokines, hormones. So a lot of anti-inflammatory cytokine will be transcribed and lead to the translation of those cytokines. So it's a multiple mechanism involved in their anti-inflammatory action. And of course, they have a greater effect compared to the NSAID, but that comes with a lot more adverse effect as well. So in terms of their pharmacology, they are anti-inflammatory when they are administered at high dose, so which means a dose that is not used for non-endocrine disease. So if you do an hormone replacement therapy, the doses are much lower, but to have the anti-inflammatory response, they have to be administered at high dose. And so they are commonly used for the treatment of RA, SLE, IBD, and other inflammatory disorder. And they also have immunosuppressant effect. And so again, these are pharmacological dose, not physiological dose. And of course, at those doses, their effect on the metabolites and electrolytes are way more intense than at the dose that would be required just to fulfill a replacement therapy. So what are the clinical considerations that are important to know? So their use is usually empirical. So that means it's based on experience, and their mechanism of action is not completely understood as something that is very complex. Their use is non-specific and palliative. So it's treating the symptoms. It doesn't treat the cause, so it's not curative. Adrenal suppression can occur due to the negative feedback regulation, and especially during the long-term therapy, which means over 2 weeks. So a single dose without harmful effect. When I got my cortisol shot, because I had that rash after being stung by the bee, they don't have adrenal suppression. Nor short-term, some patient who have allergic reaction or has like a tendinitis and treat it for like a short-term, like 1 week, it's unlikely to be harmful. But now patients who are on chronic corticoid therapy for rheumatoid arthritis or SLE, then for them, they should not cease their treatment abruptly because of the adrenal suppression, and so that means they don't have their own cortisol, and if they cease and have a stress, they are not going to produce their own cortisol, so should be withdrawn slowly for those who has been given glucocorticoid for more than a month. Intermittent dosage is preferred, so you alter the day if possible. Use the smallest dose for the desired effect is recommended. Administering the dose before 9 a.m. is also recommended to avoid adrenal insufficiency and to mimic the burst of the endogenous release. And then during long-term therapy, higher dose should be given at time of stress or like a trauma or surgery, because again, because of their adrenal suppression, they don't produce their own cortisol, and so during a trauma, they are not going to produce their own cortisol, and therefore they need to have a higher dose to cover that stress that they are undergoing. Now for the withdrawal, so this depends on the sign of the adrenal suppression, so you want to taper down over 7 days, and so you taper to 50% of the physiological value for the next months, and then you switch from multiple dose to single dose, and then you monitor for the production of the endogenous cortisol and cease the replacement when the level return to normal. Now, what about their adverse effects? So there is a long list of adverse effects. The main one, again, with the long-term use is the suppression of the HPA axis and the decrease of the endogenous hormone secretion by the negative feedback regulation over like long-term therapy, if it's over like 2 weeks. And what you should know is like the recovery may take up to 5 days to 1 year, depending on the adrenal suppression. So that's why it's very important to taper down when a patient need to stop their therapy if they've been on it for a while. They are more susceptible to infection. Also, they are at risk of osteoporosis, hyperglycemia, and glucosuria because of the effect of those glucocorticosteroid, like the physiology of cortisol. Weight gain, fluid and electrolyte disturbances, edema, hypokalemia, again, it's related to the cortisol physiology. Cataract and glaucoma, peptic ulcer by inhibiting the prostaglandin synthesis, growth retardation in children. This is, if children is on oral corticosteroid. I think we talk about the growth retardation in asthmatic pediatric patient where, they have a slow start in their growth, but then they catch up ultimately. That's for, inhaled corticosteroid. But now when they are used orally, there is a concern of maybe growth retardation if they have to use it on a long period of time. CNS effect, they affect the moods, can cause nervousness, insomnia, depression, euphoria. And then, of course, they can cause iatrogenic. So iatrogenic would mean induced Cushing syndrome. It's not caused by a hyperproduction of the glucocorticoid or the mineralocorticoid. Here is due to the addition or the intake of exogenous cortisol or a derivative of cortisol. So that's why it's called iatrogenic Cushing syndrome. And I have a slide at the end showing what Cushing syndrome look like. Now, in terms of drug, all those glucocorticosteroids, they differ with respect to their half-life and their mineralocorticoid potency versus their glucocorticoid potency. So all those Glucocorticosteroids are synthetic, and you have some that have short to medium action and low glucocorticoid potency, such as hydrocortisone. Then you have the intermediate one, such as prednisone, that is used for or as an oral anti-inflammatory and immunosuppressant. You have methylprednisolone, very common corticosteroid agent, is more potent than prednisone. And you have some that are used, as injectable one, as I said, when I got my shot. So you have the dipomedrol, solumedrol. So Depo is less soluble, long acting, again, if you remember from your principle. And then solumedrol is more soluble and more rapid active when injected. Then you have triamcinolone. Usually this one is used as a topical for, like rashes. And then you have the long-acting and very potent glucocorticosteroids, such as dexamethasone. And this is a potent anti-inflammatory drug. So here you see the quality of the slide may not be good, but it will tell you, the ratio between anti-inflammatory effect versus salt-retaining effect. And so you see here the potency of those glucocorticoid and the long-acting one. And then for the mineralocorticoid, of course, they have more effect on the salt-retaining effect. Now, mineralocorticoid, they are used for mineralocorticoid replacement therapy, and this is 9-alpha-fludrocortisone. It's a pretty new agent, binds to the aldosterone receptors and has mineralocorticoid property and also some glucocorticoid property. It's hard to do like one agent that has that is 100% either mineralocorticoid or 100% glucocorticoid, but this one is more has more mineralocorticoid activity, so retains sodium and excrete potassium. This one is indicated for the treatment of Addison disease, where you have a deficiency in the adrenal hormones, and also can be used for the treatment of adrenogenital disorder. Adverse effect, you see less adverse effect than the glucocorticosteroid, can cause edema, and then can cause hyperglycemia and reduce body growth. And now here is the other disorder of the adrenal hormone. So that's when you have an excess of adrenal hormone. So this is Cushing's syndrome. And when we talk about the endogenous, if we can say endogenous Cushing's syndrome, that would mean, overproduction of the adrenal hormone by the adrenal gland. So hypersecretion of ACTH, hypersecretion of also glucocorticoid, and or you have the iatrogenic one, which is due to the glucocorticoid therapy in large dose, as I described in the previous slides. Clinical presentation. So this is very characteristic. So you have like the moon phase, you have hyperglycemia that you don't see on this, but glycosuria, hypertension, fluid and electrolyte disturbances. So other thing that you can see like that are visible is like the buffalo hump. You have also those purpura, skin ulcer, edema, obesity. Things that you have to detect is osteoporosis. Some can develop adrenal tumor if you have hyperplasia and hyperproduction of those hormones. And so the treatment, if the gland is hyperactive, you can remove the gland, or you can treat with the aldosterone antagonists, such as spironolactone, which was covered in the diuretic chapter. And so now let's talk about Mephipristone. So Mephipristone is not a cortisol analog, but it's actually a cortisol receptor blocker, and was approved in 2012 with a highly daily dose. It's used for the treatment of hyperglycemia secondary to cortisolism in adult with endogenous Cushing syndrome. So this is new indication before, and it's still in use in combination with misoprostol. So if you remember misoprostol from your GI lecture, which is a protector of the GI membrane, but it's also inducing uterine contraction. So when those two drugs are used together, they will, produce uterine contraction and are indicated for abortion in pregnant women who are less than 49 days of pregnancy. They're also used off-label as emergency contraception and spontaneous abortion. Of course, they are adverse effect because they have an effect on the reproductive system. They can cause abnormal bleeding, and because its effect, on the cortisol receptor, they can cause hypertension and edema. So this is the last slide on adrenal gland disorders and derivative of cortisol and glucocorticoid, mineralocorticoid. In the next step, we'll talk about women health and men's health. Thank you for listening.